It's great to be here, everybody. Well, 28 years ago, I first learned about integrated care when I was hired to be the Director of Finance at Neighborhood Health Centers of Seattle. And the first day on my job, I actually met my future wife, who was hired on a grant to embed mental health clinicians and primary care clinics in the public housing projects in Seattle because in those communities, there are very large immigrant populations, and many of the folks came from cultures where going to see a mental health counselor or a drug and alcohol counselor was not a cool thing. I don't think that's the right way how they would have described it, but and so they put clinicians in the primary care clinics, and it worked. And so people would say, "Oh, I'm going to go see my doctor." So I've been following this journey for 28 years, and I can guarantee that if we had called a conference on integrated care back then, we wouldn't have these many people, right? It's really pretty exciting to see how the field has evolved. I have to tell you that I'm not going to be making lots of money off of what I say today. And in fact, it was really fun to be taught I have to put this disclosure statement in because in a couple slides I have a little screenshot that says you can download, if you don't want to go to the website for the conference, you can go to my website and you can download the PowerPoint slides, resources, 2013 California presentations. And one of the things that I feel is really important is that all the work that I do, I put into the public domain. And so there's like maybe 100 presentations and a bunch of papers. And what's fun is I put in the PowerPoints as opposed to PDFs. And so I invite everybody to take whatever slides of mine that you want out of all those 100 or so presentations and use them in whatever way you think makes sense for you, including changing the words and saying, Dale Jarvis said this. So the advanced publicity for the session, I tried to make it catchy because I was afraid that I was going to be competing with a sunny day outside. Is the fog still out there? It sure feels like home. I'm from Seattle, right? But I really think that the future of healthcare is very promising. It really is a future where the head is connected to the body. And it's a future when no one can imagine how that couldn't have been the case. And so this plenary is really a call to everybody in here to continue the work that you're doing and be thinking about becoming early adopters. I'm sort of kind of awed by the people in here. I know a number of folks. I know the amazing work that you're doing. I have this little slide of Paul Revere call to action because my wife, that woman I talked about who was running the mental health programs, she sort of describes me as a Johnny Appleseed. I have this great job. What I get to do is go around the country. I've worked in 21 states since the Affordable Care Act was signed into law, and I get to learn. I'm really a sponge. I get to, more than a CPA, I get to learn about the really cool things that people are doing to fix the healthcare system in this country. And what I want to do is share with you a bunch of stories about what I've been learning along the way the last few years. And if there's one or two or three ideas that you hadn't heard about that are relevant to you, I'll consider my time a success. I'm hoping that there may even be 4 or 5 or 6 ideas, because there's a lot of really cool things that are not only happening with you in the room, but other places that you haven't been to yet. So I'm sort of bringing you those travel stories, if you will. And Don Berwick talks about the time that we're at, this amazing time that we're at. I want to read a quote of his. Our nation is at a crossroads. The care we have simply cannot be sustained. It will not work for healthcare to chew even more deeply into our common purse. If it does, our schools will fail, our roads will fail, our competitiveness will fail, wages will continue to lag, and paradoxically, so will our health. The choice is stark: chop or improve. So let's see. I read this and I start, some days I wake up really enthusiastic. Some days I wake up and I just want to turn around and go back to bed because I'm feeling kind of pessimistic. And And this challenge before us is actually quite daunting. And, but you know, I'm a CPA, and so I do think in numbers. I counted everybody that was in the room, by the way. There's not quite 800 people here yet. And if someone were to say, Dale, what is the one thing that we could do to fix not only the healthcare system for all Americans, but especially the healthcare system where folks who are dealing with mental health, substance use, and co-occurring disorders, it would be really simple. It would be flipping the resource allocation triangle. Right now what we have is what I call not a healthcare system, but a sick care system, where all the money flows after you get sick to very high cost things, all things institutional and inpatient. So not only is it hospitals and nursing homes, but it's also jails and long-term care facilities. And we spend very, very little on the work that most of you do, which is prevention, primary care, and behavioral health services. And wouldn't it be cool if I could have one wish and wave a magic wand and have us start pushing more money, substantially more money, further upstream to adequately fund, that's a shocking term, to adequately fund primary care, early intervention, prevention, and behavioral health. So what I'm doing is realizing that I can't have that wish, so I'm working on projects to try and make that happen a little bit more slowly. I realize that change does take a long time. So in many ways, what's really great about being here is that the people in this room you're both the fix and there's some responsibility on your shoulders. Because what you're doing in terms of developing integrated systems of primary care, mental health, substance use, but let me continue, dental, social services, housing, and more, those systems of care, there's a much longer list, I ran out of space. What you're doing to bring that about is actually how we fix the healthcare system in this country, and that's what I want to talk about. Around achieving integration, there's 3 prerequisites, I think, and this idea comes from Dr. Jürgen Unitzer from the University of Washington Ames Center, who I know has worked with folks here in Los Angeles County. It's also the basis for the little agenda for my talk today. We have to design the right clinical care, we have to figure out the money, and we have to address the enormous amount of practice change that needs to occur. So I want to talk relatively briefly about those few things. But at first, I want to say I think we're at another crossroads. I alluded to this about my waking up and just trying to figure out which side of the bed I woke up on. So a cynic is a man who, when he smells the flower, looks around for a coffin. I cannot tell you how many people that I come into contact these days who hate government. They hate anybody who has a professional credential. They hate the system as it works. They think that we're all doomed, and that's kind of their frame for living their life. And it's, well, I think a lot about trauma when I hear their stories, and I realize that I know a lot of people who have a very serious trauma history, and they tend to feel that way about the world, and so I'm not trying to diss those people. I understand what led up to that for at least some of the people that are close to me. But I think that the crossroads that all of us are in the room are at are about making a choice of do we let these waves of cynicism flow into our inner beings, or do we really think about and try and put forward a different, maybe a little different view? So here's another picture. So if the glass has half air and half water, it's not ever a question about whether the glass is half empty or half full. It's actually, technically, the glass is always full. So I wish I had sensors on everyone's brains for the last 2 minutes to sort of see what your brain chemistry looked like when I showed the first picture, and then to see what your brain chemistry looked like when I showed the second. There really is a difference in holding forth, that we really can make things work better for all of us. And, having early adopters like you, it's really cool to be here because I really know that many of you are early adopters with a clear vision of the future, and the tools for getting there will make the difference. So let's dig into some of the content. Prerequisite number 1, the right clinical care. And I want to first talk about what is a health neighborhood. So how many of you know about Atlanta's health neighborhoods and their one-stops? Okay, so soon all of you are going to be able to raise your hand. Fulton County, Georgia, which covers a big part of Atlanta, has this objective to create health neighborhoods that contain one-stop centers where people receive a holistic set of services under one roof that are customized to the needs of the neighborhood. Very simple sounding idea. And they, through a series of very clever maneuvers, got funding to develop the bricks and mortar renovations for 4 one-stops. The Neighborhood Union Primary Care Partnership was the first one. I had the opportunity to go there and do a site visit of the 2 one-stops that were up and running. So I go to this first clinic. It's an old school, and it's not really fancy on the outside. It still looks like an old elementary school. But when I go in, it's been remodeled, and I start walking around, and my gosh, they've got well patient care, sick patient care, OBGYN services, travel immunization services, communicable disease intervention, WIC, nutrition education, oral health, behavioral health, and employment assistance, disability and voc rehab, foreclosure prevention services, housing assistance. Okay, so this is what's inside in this elementary school. And it's not like there's one organization. The county funded the remodel of this building, but there's lots of community partners in there. There's a federally qualified health center, there's a bunch of social service agencies, there's the county mental health program and the county drug and alcohol program that they've been working on merging. And they're all working together so that people truly have a one-stop. So that rather than you having to go to 5 or 6 different places during the course of, well, how long it's going to take you to get all these things, whatever you need taken care of, you go into one building. You may not get everything on the same day, but then again, you might. So then I go to the second one-stop. So this one-stop was built before they started this one-stop initiative in earnest. And so then we go to I go to the second one-stop in the North County. This is with Dr. Patrice Harris, who's the head, a psychiatrist, and who's the head of the whole health system there. She's also on the board of the American Medical Association. And the second one-stop has everything that's in the first one-stop, but there's also a daycare center for kids. There's a branch of the public library. There's a reading room and information center that offers English as a second language classes. There's an office where you can pay your taxes and parking tickets. Talk about one-stops. And then here's a look. These are Google Earth shots, so you can see there's all this greenery around this building. There's a farmer's market, a community garden, and a walking trail. Now I go everywhere I go. People are developing these one-stops. It's not just in Fulton County. I know it's happening here in California. It's happening in earnest in LA. I'll talk a little bit about that in a couple minutes. But this is very exciting because it looks very different than going into a primary care clinic that has a social worker who's got an office down the hall that everyone forgot that they were even there. So, people around the country are running with this concept. So here's just some snapshots of the Kitsap County Behavioral Health Alliance and the Kitsap Peninsula right next to the Olympic National Forest. Portland, a Central City Concern, Asian Counseling and Referral Service, Navos Center for Behavioral Solutions. All these different kinds of behavioral health-oriented organizations are in the process of building one-stops, sometimes with money for new buildings, sometimes not. And so what's really cool about what's happening in this country is the diversity is playing out in the form of the customization of the medical home. There's a fellow who lives in California, Arnie Milstein, who's a doc, who's a thought leader, and he was talking at a conference in San Francisco about 5 years ago, and he said, if you think that this thing called the patient-centered medical home is going to be one thing that has this fidelity scale and everyone looks exactly the same, you're wrong. That what we need is the customization of the medical home to address the whole health needs of the people that are living in the community that use that medical home. And so here's another case in point. Why did I blank on his name? Who recognizes this fellow? Dean Ornish, thank you. So Dean Ornish has been working for 16 years to get his health and wellness program for people with heart disease approved by Medicare. He finally got it approved. And he has a customized health and wellness center for people with serious heart disease. And it's cool, if you look at who works there, there's a doc, an exercise physiologist, a stress management specialist. There's a whole crew of folks working on nutrition, fitness, love and support, stress management, and, by the way, medical care. And you notice how I was deliberate in saying, and by the way, medical care, because you know, that is a very small slice of what helps people achieve health, medical care. And if you look at the stress management specialists, we're talking about somebody that's been trained in yoga and breathing techniques and cool things like that. Really talking about needing to think well about the whole health. Again, I'm a little embarrassed telling you this because I know that this is in the DNA of most of the people in this room. But again, in the interest of telling stories, I want us to think very much more expansively maybe than we did yesterday about what the future health and wellness center all throughout America is going to look like. In Los Angeles County, there's more than just the things I had in my slide. There's a large number of partners that are being invited to join the health neighborhood. I know you can't read this, but it's in the slide packet. This is a picture of their roadmap, again, a listing of all the different kinds of services, mentoring services, law enforcement, schools, fire departments. Like I said, I didn't have enough time to write everything down. Domestic violence services, faith-based organizations. We're really talking about leveraging the concept of collective impact to create these one-stop health and wellness centers that are sometimes physical and sometimes virtual. So I feel like for me, after the last 4 or 5 years, the crystal ball is starting to get clear. And what I'm starting to see is that the future, anyone recognize there's a great future in plastics? Yeah. I know most of you are too young to recognize that. But the future is neither in plastics nor patient-centered medical homes. I know that may sound like heresy, but the future is not in patient-centered medical homes. It's in one-stop health and wellness centers providing integrated whole health care. And those one-stops are combined with specialty care that includes medical, behavioral health, inpatient, and ambulatory hospital provided at centers of excellence. So for me, the future is really simple. You've got these cool one-stops that have, depending on what neighborhood you live in, it has what you need to move towards health. And there's a need, and if I need more than what's in that one-stop, I'm connected to a center of excellence that's providing specialty behavioral health care, whether it's because I've had a heart attack or whether it's because I might have a heart attack soon and I need a cardiologist and there isn't a cardiologist in the one-stop, or I have a serious mental illness that may not be something that one-stop does a great job at. And those two entities or groups need to be supported by payment reform, because we can't do this without flipping the resource allocation triangle. And this is the health neighborhood. This is one definition, one description of the health neighborhood. So I want to shift gears a little bit and get drill down into some of the clinical aspects of what needs to be in these one-stops. It's kind of funny for somebody who has a CPA behind their names. Oh, this is great. I forgot to tell you. And it goes along with talking about clinical stuff and being a CPA. So I've looked back over I've been consulting for 26 years now, and about 5 years ago, I went and I looked at all the projects that I worked on and all the predictions I'd made for in the last 20 years, and I realized that I'd only been right about half the time. I should have said this at the beginning, when I did the disclosure statement. So what that means is that everything that I say, well, it could be right or it could be wrong. And well, why did you bring me here if I'm only right half the time? Well, what's great is because what it means is that you have to put on your thinking cap and you have to run every idea through your brain about whether this makes sense in your community, whether my prediction is right, whether what I'm saying you ought to be doing is right or not in your community and your setting with the folks that you're working with or not. And so it's actually kind of cool because now you know that I'm not the expert and that you just can't take and run with what I have to say. So I'm thinking about integration workflows. And I have 2 workflows I want to briefly talk about. This first one is a variation on the University of Washington Ames Center impact model. And so I'm in a one-stop. I'm going to be a patient at a one-stop health and wellness center. And in my first visit, my primary care provider does a screen for behavioral health issues. And if it looks like maybe there's something going on that I could benefit from cure possible issues, there's an attempt to make, you've all heard the term, a warm handoff to a behavioral health clinician, a behavioral health professional who will do a full assessment. They're working in the clinic. This isn't a primary care clinic. The hub of the one-stop is a primary care clinic. The hub of every one-stop is not necessarily a primary care clinic. And if I need behavioral health services, there's 3 doors that I might be invited to choose from. The first door is if I have a low to moderate behavioral health need. In Washington State, we call this a level 1 authorization type, where I'd get my behavioral health care in the primary care clinic managed by the primary care clinician, behavioral health coordinator, team supported by a consulting psychiatrist, and other clinic-based mental health professionals. So I'm getting, you all know this, I'm getting my behavioral health care in the primary care clinic. Now, let's just say that I come in and that's my presenting problems look like, okay, Dale would benefit from being a level 1 type of service. But then it turns out that after a few visits, there's a lot more going on. Well, level 2 is the term that's used in Washington, again, where clients with high, moderate to high need are referred to level 2 specialty care. So I'm referred to a specialist in the same way that I'd be referred to a cardiologist or an otolaryngologist. The primary care provider continues to provide medical services and behavioral health care coordinator maintains a linkage, but I have a care plan that's been developed at the specialty behavioral health clinic that becomes part of my larger care plan. And so that part of my specialty care is transferred. I've been stepped up, is the technical term that's used, with the expectation that after some period of time, I'll be stepped back down again because the specialist will have stabilized what I needed and I can be served again in primary care. So this is the extent to which the impact model has been designed in Washington State. 2 levels, treatment in primary care or treatment in primary care plus the addition of a specialist. But the thing that I've been scratching my head about is what happens if it really turns out that I have a very serious mental illness and I need more than 6 or 12 months worth of specialty behavioral health care. So the addition that I'm proposing to make to the model is a level 3. And this is clients who have a serious mental illness or a serious co-occurring disorder. Their care would be transferred to a community behavioral health organization that had an embedded primary care clinic. We know that this is rolling out across the country. SAMHSA, HRSA are pushing this. We know that there are models in Los Angeles County of these primary care clinics that are embedded in behavioral health centers for folks with serious behavioral health disorders, that would become my new health. My care would be, I would shift my primary care provider if I was in a level 3. If I was choosing to go through door number 3 is really a better way to say it. And so I've been talking with folks about this level 3, and people go, well, gosh, you're just creating another ghetto. You're creating a 2-tiered system. And maybe, but I actually think from talking to clients who use this service at my neighborhood mental health center, because we do have a primary care clinic embedded. They are a level 3 type organization. They say, when I went to the doctor would give me I'd have this 10-minute visit, and they'd be blabbing at me in language that I didn't understand, and they'd be out the door before they said, do you have any questions? Or they would say, do you have any questions, as they were walking out the door? And now, when I go to Navos and I have a primary care visit, the doctor sits with me and talks with me, and we spend a half hour, 45 minutes, and I don't leave until I completely got what was going on, and we came up with a plan. And that's the difference, I think. And so I believe that if you don't add a level 3, it's a serious problem in the healthcare system that's not being addressed if we don't have those level 3 options. And if I had a serious mental illness that required me to, or if my day comes when I do, because it's very possible that could happen, I would like to think about having my place of my one-stop be one of these behavioral health centers, and one of my first sort of major milestones after I get through little milestone treatment goals would be to graduate from planned care. So I would no longer have a behavioral health treatment plan. I would use other services that were informal, but I keep my primary care clinic. I still have that lifeline of going to see my doc at that place where I can get those 45-minute visits. And then potentially my next step in my recovery plan would be to kind of get mainstream back to the primary care clinic, and I'd come back to a primary care clinic that didn't have a mental health clinic. I think that this model is a very recovery-oriented model. So that's a lot of words well, let's see, there are a lot of words on the screen that you can't read because they're so far away. But that's a lot of words for one little simple flow chart. But let me talk about a second workflow. And that is, let's just say that I moved to Los Angeles County, and I was dealing with a serious behavioral health disorder. Let's just say it's a serious mental illness, and my first place to go is a mental health center. And so in this workflow, this is the expectation that I am going to have for all of California, all of the country, that when I go into a behavioral health center, my first visit will include a physical health screening. Remember, I'm in a community mental health center. And the one question will be, does Dale have a primary care provider? If the answer is yes, then the center connects up with my primary care provider. So there's a linkage model that's invoked, where the mental health center connects with the primary care clinic, ensuring that they're moving into a realm, if I have health conditions, of co-managing my conditions. Let's just say that I have major depression and diabetes. That sounds familiar. Then the mental health center would be involved in co-managing my diabetes. If I don't have a primary care provider, the center would say, do you want us to be your primary care provider? And if the answer is yes, if the answer is no, then they'll say, well, let me get you connected up with the primary care clinic so we can co-manage your diabetes with them. Or if I say, yeah, I do want to have you be my primary care clinic, then let me pretend for a minute that you all work in a mental health center. You would have a partnership with model number 2, a partnership with a primary care clinic, an FQHC, a rural health center, or just a regular non-federally funded clinic to embed a primary care provider team in the clinic, or or the third model is you would be an organization that hired the docs, and you were both a fairly qualified health center and a community health center, or whatever it might be. So for me, it's really simple. Wherever I go, the anchor tenants of these one-stops really need to be primary care, mental health, substance use disorder treatment services. Those are the three anchor tenants. Integrated care. It doesn't matter whether I'm going into a primary care clinic or a mental health center, because it's all, pretty soon it's going to all look kind of the same. Is that shocking to predict or to say? Okay, so let's see. I've got this great little thing, this little LED dial on here, so I can keep track of my time, and it said 10 o'clock for the last half hour. So I think I better check my watch. Oh, it's 10 o'clock. Isn't, what they say, that a clock that ran out of batteries, it's always right twice a day? Okay, anyway, sorry. What's really a big problem in my household, in addition to the fact that my wife is a marriage and family therapist who's been a clinician for many years and knows me better than I know myself, but is very kind to me. But what's a problem in my household is not that. It's that I have a really dry sense of humor, and my wife only knows about half the time when I'm telling a joke. And you can imagine how embarrassing that gets sometimes. But so anyways, on with the show. So we've got these people out there. Let's see, it's you that are trying to figure out what kind of behavioral health providers to put into primary care clinics, and then what kind of primary care providers to put into behavioral health clinics. And it's almost kind of like there's a war going on. So there's all these competing factions. So for example, I'm working on a lot of projects in Oregon, and one part of Oregon, there's this university called George Fox University, and they have a psychology PhD program that has a big section of their training to teach clinicians to be behaviorists, and or behavioral health consultants. And what they're doing is they're embedding these behaviorists in these primary care clinics. And so what the behaviorist does is, works with health behaviors. This is a fun flipping of the words. They work with behavioral health issues, and they work with health behavior issues. But their treatment model is, their goal is 20-minute visits. 3 visits consists of a complete episode of behaviorist care. Okay, so some people are scrunching. No, they're not doing mental health or substance use treatment. What they're doing is they're doing early intervention, identifying what the issues are, the health behavior or the behavioral health issues that people have. If they can resolve them in 3 20-minute visits, that's great. If not, they make sure that they get referred on elsewhere. So some places are embedding those folks. And then there's other people who follow the UW Ames school that's saying, that's a stupid idea because there's all these other things that people have when they come in the clinic. So then there's the Ames impact model where they have team-based care. And so I'm like this outsider who knows nothing. Let's see. I've always wanted to put my business cards, have 2 business cards. I know nothing, but everything I know is right. And so that's kind of like where I'm coming from here. The other one is I know everything, but everything I know is wrong. And I'm going, you know what? It's not about an or solution. So my prediction is we're talking about a very robust team as an and solution within the primary care clinic that's going to soon become a health and wellness center that you soon won't be able to tell the difference from any other health and wellness center, is we need this type of workforce. We need the behaviorists, we need the behavioral health care coordinators, we need peer counselors and health coaches, we need therapists, we need consulting psychiatrists. Those are the folks that have the flavor of behavioral health, in addition to having a rich set of knowledge about helping manage diabetes and asthma and hypertension and things like that. And so it's not like there's a degree of specialist, but there's also a degree of generalist in all these positions. One of the projects that I won't talk about is totally depressing me. Let's see, I probably shouldn't even talk about it. I won't even talk about where it is because the psychiatrist doesn't want to have anything to do with people's diabetes and hypertension. He said, that's not my job. And I'm going, yeah, that's not where we need to go. So workflow number one. Okay, so there's a couple things that are going on that I'll talk about in a few minutes more about what the behavioral health folks ought to be doing as they get embedded into primary care. The first thing is becoming best friends with the primary care clinic folks. But there are 4 concrete sort of pieces that need to happen. So this is, actually what I'm talking about now is I've got my little model here, workflow number 1, where Dale got primary care. His problem is more complex and needs to be stepped up to specialty care. What should the specialists, I misspoke a minute ago, what should the specialists be able to bring to the table to be best friends with primary care? So pretend for a minute that everybody in this room is a behavioral health clinician or administrator who works in a specialty behavioral health clinic. Now I'm speaking to you. Need to have rapid access to care. Can a medical clinic get its patients in same day, next day for folks who have high need? Are you providing outcome-based care? This is a much longer topic around treat to target team-based care, but are you measuring where people are at with their PHQ-9 or their CAGE or their GAD-7, their depression, substance use disorder, anxiety, and are you setting targets and helping people move towards targets, and if they're not reaching those targets, are you changing the care plan? Are you providing high-value services? The services are effective, the services are more cost-effective than other options, the services are lean. I won't go into details about this, but I just want to stop and say, Dale's throwing a lot of words at you, and what I'm talking about now is, in the future, what I think is going to happen with most Americans when healthcare reform succeeds is that the primary care team, which may be the primary care, the physician or the nurse practitioner or the physician's assistant or the nurse care manager or the behavioral health care manager, the primary care team in the primary care clinic is going to have a huge impact on where I go for my specialty care. So again, I'm pretending that you all work in a specialty behavioral health clinic. That primary care team, as they figure out how to succeed at helping their patients move towards health, I can tell you that there's one thing that they're going to do that you may not know about now. They're going to become vehement about making sure that every one of their patients who needs to be referred to a specialist is going to get referred to a high-performing, high-quality, high-touch, outcomes-based specialist. So think about a cardiologist. Do you want a cardiologist who loses half their patients? Probably not. Do you want an otolaryngologist who misses the diagnosis half the time? What we're talking about is primary care docs and the rest of the team are going to be, in the new healthcare ecosystem that's coming tomorrow, they're going to be referring their patients to only high-performing behavioral health specialty clinics. And if you don't have rapid access to care, if you don't do outcome-based care, if you don't provide high-value services, and last but not least by any stretch, if you don't provide world-class customer service, think Nordstrom, Amazon, Starbucks, Apple, and UPS, then that connection won't be successful. They'll basically say, you're not my best friend, I need to find another behavioral health provider. So this is really cool because those of you that are thinking, if I pretended for a minute that you're all specialty behavioral health providers or you were on that side, that's the competitive advantage and distinct competency that you can bring to the table if you get to these 4 pieces. Okay, shifting gears now Dale's going into the behavioral health center for his first visit. What they figured out in Missouri was that if they turn their case managers into care managers, they can save the healthcare system a lot of money. And they did a pilot project. They saved, for the patients, the clients they served in behavioral health doing care management, case management, everybody knows what that is. You're doing cool things to helping people lead as fulfilling lives as possible, but you're not even thinking about people's diabetes and depression and hypertension and asthma. A care manager is simply helping treat them and helping co-manage the medical conditions onto a case manager role. When they started doing that, they saved $6,000 of health care per year for the average of the patients that they were serving. They became so successful that they've moved to phase 2. And what they've done, so the Missouri model is the creation of community mental health center healthcare homes. Remember I was talking about level 3? What they're doing is they're fundamentally, in the state of Missouri, they're fundamentally redefining what a community mental health center is. And so let's look at what they're doing. They're addressing the whole health needs of the behavioral health consumers. Is that shocking? Well, it's just what you all are thinking about and talking about. And these are 6 examples of the conditions that they're treating: diabetes, cardiovascular disease, COPD, obesity, tobacco use, and for some reason they included developmental disabilities in there because they are being treated elsewhere in the system. The 26 community mental health centers in Missouri are not necessarily becoming medical clinics. They're either using the linkage model, the partnership model, or the full integration model. There's no recipe for what they need to do. But what's really important about this is that they have a well-defined model that, like I said, shifting from case management to care management with the appropriate medical support. They have the appropriate medical support in the clinics to be able to do that care management. And so they have one physician for 1 hour per enrollee per year. 1 hour per enrollee per year is what they're not doing this person isn't doing primary care, this person is supervising the whole team. They have at least one nurse care manager, so they've embedded at least a part of a doc and at least one RN to support the behavioral health folks, medically oriented RN to support the behavioral health folks. The model is a fundamental reinvention of the community mental health center in the United States. And I think that's where we're going. Okay, so let's see. I'm going to talk just a few minutes about the money because it's just so boring. Are there any other CPA accountant types in the room? Okay, there's one. So what we have, I want to talk a little bit more about that upside-down triangle. So in the current financing environment, if achieving financial sustainability of an integrated care program is not easy, do I have any disagreement? Because most of the money in healthcare flows after people get sick. And we know it goes to emergency rooms, hospitals, and paying for high-cost diagnostic imaging and specialty procedure-based care, leaving little money to help prevent those, the development of the programs that you're trying to work on. So that's what I'm kind of freaking out about now in California and in Oregon and in Washington and in Colorado and other places I'm working, is there's not enough money to fund these projects, except if you have these grant dollars like MHSA. And to add insult to injury, there's at least 10 barriers that I'm not going to go into right now, but there's a toolkit that you can download from the CIMH website about getting paid for integrated care. 10 barriers that make it hard. Not only is there not enough money, but they put up, there's 10 barriers to actually tapping into the little amount of money that's available. So here's what normally happens with an integrated care program. And let's see. I hope that you laugh when I show you this because let's see, I hope if you laugh when I show you this, it's not because it's a nervous laugh because this is what's happened with you, but let me try it on for size and see what happens. Here's what typically happens. Hooray! We got a grant to start an integrated pilot. But the grant lasts for only 2 years and we don't think we can generate billings to cover the cost. That's okay. Let's get the program started and we'll figure it out. We've got 2 years. Time passes. 2 years are up, and nothing has been done to build the business case to sustain the program. I cannot tell you how many projects I've touched that have already been underway that are doing this beautiful recreation of this trajectory here. And so what we're doing at CIMH is trying to come up with a new plan to help you do something different. It's only 4 steps. You can memorize them in 5 minutes and take it back to wherever you're working. And it's organized for sustainability, serve high-cost individuals, track and analyze health cost and utilization, build the business case. So I'm going to say a few words about this, and then we'll move on to the next topic. So organized for sustainability has a few parts to it. It's really quite simple. You need to become best friends with the health plans. I didn't say the health providers, the health plans that are serving your clients, that are at risk for your clients. So let me just use a California medical example. Everybody in California is being moved into managed care, which means they're all signing up for a health plan. And so all of your clients, if you're in California who have Medi-Cal, are probably going from fee-for-service, which is what most of them are in, to being connected with the health plan, which means that the health plan is at risk for their total health care expenditures. Oh my gosh, they're at risk for your complicated patients, clients. You want to become best friends with them, and they want to become best friends with you. So you do that, you develop a hotspotting strategy to identify high-cost folks who are costing the healthcare system lots of money, and you develop a tracking system to say how much are we bending the cost curve? Are we saving healthcare dollars? By doing integrated care, are we lowering emergency room utilization, inpatient utilization, and are we saving money? And are we hitting quality measures? And if you can organize this on the front end, having a steering committee that has the health plans for the clients that you're going to be serving in this integrated care pilot, you are light years ahead of folks that haven't done this. And if you're well into a project, what you simply do is you loop back around and you start doing this. So then, the second thing you do is you focus on, this is a iterative, rapid cycle improvement style model where you start with the most expensive folks in terms of their healthcare dollars, and you successfully wrap care around them. And you basically become emergency room and hospital prevention systems. And I have a prediction that if you don't start an integrated care program focusing on these high-cost folks, you may not be able to show cost-benefit, and people are just going to say, they're going to blow you off when they want you to sustain the funding. So I'm basically saying you need to use a Jeffrey Brenner hotspotting approach. And the third thing that you do is you track how you're doing. And you use a patient registry, you use a spreadsheet, you use your electronic medical records, you do whatever the heck you can figure out. In the new Care Coordination Collaborative that CIMH is starting up next month, I think they're going to be using, there's a new Canadian patient registry type tool that I think we're bringing to California. And so if you don't have something like this, tune into what's going on at CIMH. And fourth is you build the business case. You compute the actual and projected cost savings. You develop a little return on investment analysis. And then you go to the payers, the health plans, and other folks, and you say, guess what? You do what Missouri did. We saved you $500 per person per month of health care costs from this intervention that we did. $6,000 a year of healthcare costs is what Missouri did for the same kind of patients that I'm talking about being your target population in your project. And then you expand the program and you keep building. So you start with this little project with the most high-cost folks where you think you can bend the cost curve. You revise the design, you expand the population to serve. It's in my second circle. You continue tracking, you continue building the business case. You expand again. You create a virtuous cycle. What's happening is if you do this, the health plan will gladly pay. Okay, if you do this and you say, you know what? It only costs us like for every dollar that you saved, it only costs us 25 cents or 30 cents to sustain this program. We're asking for a grant or a case rate or capitation payment, not of the full dollar that we saved you, of the 25 to 30 cents. Over time, the savings will get a little less because you'll be treating folks with less complicated conditions, but it still is a great deal for the health plan, and it makes your health plan look like a hero because they're bending the cost curve faster than their competitors because they have you who's doing the work, who brought them in on the ground floor to help them succeed at what they were hired to do. So this is like this win-win situation just that may be sitting there on your doorstep, but you haven't opened your door to sort of bring in the paper metaphorically. With the ultimate objective is to increase funding for both primary care and behavioral health, properly allocate the dollars to meet the needs of folks with mild, moderate, serious, and severe disorders. And what my prediction is, if you think about what I just said, we're using health care dollars to fund the integration, the shortfall in the integration program. What I'm predicting is going to happen is the specialty funding that's in the yellow box, which is a lot smaller than the medical care dollars, is going to get well focused on folks with serious and severe disorders to address their behavioral health needs. And general health care is going to spend money on behavioral health to fund the behavioral health for those with mild and moderate disorders. Let's see, I'm going to talk really fast for the last few slides because I want to have time for a few questions. We have to address the enormous amount of practice change. Primary care in this country is obscenely underfunded. I'm not going to talk about that slide. You can look at it. We can't expect robust practice transformation in primary care, a primary care system that's underfunded and overworked. That's a really important piece of the puzzle. Brenda Reese-Brennan, who some of you may know from Intermountain Healthcare, said something to me that was really great. She said, what they do in Intermountain in Utah is they go to the primary care clinics and they say, how can I help you deal with your most complex patients, get home for dinner with your family more nights of the week, keep you awake at night, including call. That's the proposition that the behavioral health folks are pitching to become best ones with the primary care clinic, to help support acceptance in the primary care clinic of the behavioral health workforce. But let me say, this is from a young woman in Vermont who's a care manager. Relationships are everything. And so I'm thinking about behavioral health clinicians that are being embedded in a primary care clinic. The best way to help support transformation is to actually have really fabulous, extroverted, friendly people who are also behavioral health clinicians on the side, go work in primary care clinics, be flexible and adaptable, conceptualize issues across the developmental levels, experience with co-occurring disorders, efficient, strength-based, et cetera, collaborative spirit. Supporting behavioral health, there's this concept of behavioral centers of excellence that I'm not going to talk about more than just a minute now, but we're working on this in Los Angeles County as well as at the National Council for Behavioral Health. What we're hoping is that the behavioral health centers in this country will start to be seen as the Mayo Clinic of the behavioral health in their community. And a behavioral center of excellence is successfully implementing a philosophy of excellence that percolates into the community and achieving outstanding performance. A philosophy and high performance so that you're seen as a great place to work and a great place to get care. So you'll be hearing more about this in the next year, but this is a really important piece of the puzzle to support the transformation of practices. Both are going to require something similar to what Oregon is doing, which is a statewide integrated care, a transformation funding pool, a transformation center, transformation performance metrics, transformation incentives, and transformation advisors. So with that, I think we have like 16 seconds for about 10 questions. I think it's available online at the conference website. And if you go to djconsult.net, my website, you can find it there too. If you start telling people that they should go get their medical care at the mental health center because we don't really want them at the primary care clinic because they don't make the waiting room look nice. That was what people have said.
How do you respond to that?
And so what I've said is that well, first, people, what you do is you create choice. You say to Dale, you can get your care here, you can get your primary care at a primary care clinic, and if you don't feel comfortable at the primary care clinic because you've been dissed like 100,000 times, I would probably want to choose to go, as opposed to being told, oh no, you're assigned here and you have to go here because this is the only place that you're allowed to go. It's really simple when you have a longer conversation that it's actually a recovery-oriented strategy rather than a stigma-promoting strategy. The question is, Dale, you really talked mostly about mental health and you didn't really talk about substance abuse. So in 3 minutes, could you do another presentation about how all this relates to people with substance use disorders? One of the problems that you all are finding is that there's all these great folks that are working in addiction treatment centers that don't have a license or don't have the right kind of license to bill insurance or they're just not getting the respect that they deserve for 27 other reasons. But the workforce licensure there's two things I want to say. The workforce licensure is a really key piece. So what would happen if tomorrow, okay, so let me give you an example of what's happening in Oregon. A federally qualified health centers, 3 of them are getting subcapitated from the feds. And what that means, from the state with a permission from the feds. What that means is rather than billing on a fee-for-service basis, that's with only licensed LSCWs and psychologists and psychiatrists or nurses, they're getting a pot of money to serve all their patients for the medical and their behavioral health, and soon to be their behavioral health needs. And that FQHC can hire LMFTs, unlike other FQHCs, to provide mental health services. They can hire chemical addiction counselors. They can hire peers. They can hire whatever workforce they want in this new payment model for federally funded health centers without any of the rules around you have to have this license. And so what I see happening is that what California needs to do faster than it's doing now is move away from fee-for-service and their healthcare system to a capitation model that follows the Oregon design. Folks from the CPCA have already gone up to Oregon. And what that will do is that will allow substance use treatment disorder clinicians, whether they're licensed or not, to have a full range of practice within the scope of whatever licensure or non-licensure they have in the clinics under the proper supervision. That's a huge, huge change. The other piece is we gotta get to co-occurring disorder competency among the whole workforce, because if I'm a doc and I'm doing a screening of Dale and Dale has something going on and I don't know if it's a drug problem or an alcohol problem or depression or psychosis, I don't know. Okay, what I want to do is I want to walk down the hall to the behavioral health professional to do a full assessment. And if I'm in my clinic, I have a mental health clinician and a substance use disorder treatment clinician, and one is at one end of that hall and the other's at that end of the other hall, I don't know which way to go. And so for us to get to where so the medical community just is like blown away that they would have to embed 2 people to treat one person who had a co-occurring disorder or whatever, or to two people to figure out whether it's one or the other or both. So I think it's really important to change the payment models to allow this wonderful workforce that's been doing great work for decades to be embedded in all the kinds of health homes, health neighborhoods, to get paid for the work that they're doing. But if we don't get to co-occurring disorder competency, well, I don't want to say we're toast, but it's a big problem. Behavioral health centers of excellence. So I would really love for everybody in this room to be working in an organization that was seen by everybody in your neighborhood, in your community, as a great place to work and a great place to get care. And if that isn't how you feel about where you work now, that's the aspiration that you should shoot for. Because if you're seen as a great place to work and a great place to get care, you're going to become a magnet for people that want your services. You're going to become a magnet for people that want to work there. You're going to become a magnet for the healthcare system that's going to be referring folks to high-performing specialty care, and it's a really important piece of the puzzle. And this is both true for primary care clinics and specialty clinics. And I really encourage you to track the Center of Excellence work that Los Angeles County is going to be doing and what the National Council is going to be doing. So I just wanted to say another special pitch for that. The other piece that I want to say is thank God for MHSA in California, but I know not everyone's from California. There has to be ongoing continued transformation dollars to support this effort, because this is how we fix the healthcare system. You folks are the people that are going to fix the healthcare system, not people who work in hospitals or rehab facilities or cardiologist offices. And so I don't know if you feel that important. I don't know if you feel that powerful, but I have a prediction that within 5 years, everybody in this room is going to have a great job that you love. You're going to be getting paid more money, and you're going to be getting an enormous amount of respect from everybody that works in healthcare, because this is the center of action of healthcare reform in this country. It's like amazingly exciting. So give yourselves a hand, and then we'll do some more questions. This woman is a mental health contractor in Los Angeles County, and she's works at a relatively small agency, and she's having a little bit of difficulty getting traction with FQHCs because they want to hire their own behavioral health folks. I think you're the only person in the room that has that problem. Okay, so this is a really important issue, and let's see. There's 3 things I want to say. If I had 2 wishes, you heard what my first wish was, which is flip the resource allocation triangle. My second wish would be that CMS would put out a third round of innovation grants to the tune of $1 billion, a proposal. But the proposal would be very focused. It'd be focused on, we are going to give grants out to organizations around the country that do a 2-part one thing, where a health center and a behavioral health center merges into a single organization and provides truly integrated care. Because I believe that in 20 years, that's what the future's going to look like. That there will be specialty behavioral health providers, but they will be really small in number, and most of the work that you're doing will be under one corporate umbrella of an organization that does healthcare and behavioral health care. So if that's the future, what about now? And now I think there's 2 things that we need to do. I really am a big fan of the Verizon model. And so I don't have a Verizon, I have AT&T. So remember, I'm not promoting any products. But when I say I'm a big fan of the Verizon model, what I really worry about is an FQHC hiring a social worker and there being no crisis backup, there being no psychiatric consultation, that person decompensates and in a very serious way. And if it hasn't happened yet to a center that's done this, it's going to happen. And they don't have anybody to turn to except, they haven't built the relationships. And so this idea of a partnership model of a community mental health center, a community behavioral health organization, embedding clinicians, I can tell you, it's a huge pain in the butt because you don't have supervision ability over those people. If they're not a nice person, you don't have much control over them. If they don't speak Spanish, and the behavioral health center said, well, this is your person, tough luck, it's a real problem. But if you can provide the right folks to that in the partnership model, but more importantly, you can pitch the Verizon model that we have this whole system of backup. You're not buying, Joe, the social worker. What you're buying is Joe and the other 100 people that work with Joe for anything that you need. I really suggest pushing the Verizon model. The second thing that a colleague of mine that runs, I spent the last week with, that runs behavioral health carve-out system in rural Oregon, most of the counties in rural Oregon, what he said to his centers is, you should, there's a number of clinics where you should give them your money so that they can hire their own clinicians. Because there are some cases where that's the right thing to do, and you should not, there's a difference between control and power. And what I mean by difference between control and power is I need to hire that person, I need to have that person on my payroll, I need to control them, I need to control the behavioral health space. But what Kevin was saying is that I know that many of you aren't in this position, but if you were in a position where they said, we're going to hire our own person, and you said, good, we'll use some of our money to help support them, you've just created a best friend for when they need referrals to specialty care. So I'm not a big fan necessarily of, I'm two things. I'm a big fan of the Verizon model, and I'm not a big fan on forcing primary care clinics to have to embed mental health clinicians or chemical dependency treatment counselors in their clinics who get paid for by other organizations. It's very, very complex, and we're just going to need to play this out until we all become one, as the saying goes.
Just as a follow-up to that question, as we've tried to follow that model in California, one of the things we've run into is the potential of not being able to draw down Medicaid funds associated with that because of the FQHC problem. So on a national level, are there workarounds? Because we're looking for them, but so far we haven't found them.
Oh yeah, so thanks, because that's the third piece of the business case is if I can embed clinicians that do really cool work in your FQHC that aren't LCSWs, like you were saying, peer coaches and other clinicians and CACs, and I can pull down Medi-Cal dollars for that. So if we just did a simple math problem of how much money could we bring from short-term Medi-Cal or drug Medi-Cal into the program to help support it. This is the first half. We could actually make we could increase your virtual budget so that you're bringing more FTEs to bear with more dollars. So we can actually leverage dollars. But the other piece is if California Primary Care Association moves more quickly, or when it moves to capitation model like Oregon, you'll be able to draw down those people who who are being paid for by short-term Medi-Cal could go become employees of the health center, and you could draw down federal dollars via the FQHC without having all the rules that you have now. So that's actually, so I think both strategies are really important to think about. So we're going to come back to you with more about the wiring of the money, because this is an ongoing issue that you're all being, not all of you, many of you are being, well, I don't want to say crushed by, but it's a big deal. Other questions?
Just wondered if you could speak a little bit, if you put yourself on the side of the managed care plans that are currently seeing a big change that's coming in January 2014 with the expanded benefit. How the FQHC, I see that piece pretty, the possibilities and challenges in that area. But from the specialty mental health side, we're having to grapple a lot with these changes. So from a fiscal and payment structure, and how do we see that, sort of the interim sort of step?
Yeah, so there's all these folks who are going to have a benefit for mental health services that don't go through the county mental health authorities, and that's in two places. It's on the Medi-Cal side and it's on the exchange side. And it's for private insurance too, but the exchange is new and the Medi-Cal benefit is new. And so they got to build, they're rapidly building networks. They have to build networks because they have to, they're under the parity, the federal parity laws, where they have to have an adequate supply of mental health and chemical dependency counselors. And so what's happening is going to be a little bit of challenging, because they don't know you, you don't know them. They generally want to pay less than what counties pay. It's not the whole cost report thing. And so I think we're going to see some real road bumps, especially around payment rates, because in California you've gotten used to this cost-based reimbursement model, and what they want to pay you is less. So when I talked about being best friends, I said providing efficient care. If the cost of your services are high cost, if the unit costs for your services are high, you're going to have a hard time becoming best friends with the health plans, and they're just not going to listen to all the great things that you can do clinically. If you're not demonstrating, if you don't provide outcome-based care, if you can't demonstrate you're going to have outcomes, you're going to have a hard time. But let me just flip that around and say that if you provide rapid access to care, outcome-based care, efficient care, and you have great customer service, those four things, you could go to any health plan in California and pitch that, and they're kind of desperate for getting folks. I know that some of the health plans are working with counties and using the county networks, so that's the other piece of the puzzle, is if you're in a county where there's a Medi-Cal health plan that has responsibility for mental health and drug and alcohol services for the folks with more mild and moderate disorders, and the county has said, we'll supply our network, then you've already got an in, but that's not happening everywhere. This is what your question is, like about a 2-hour brainstorming session. So thanks everybody for your time. Have a great life if I don't see you again.